My name is Nancy Barlow. I'm the wellness coordinator at Pro. We have some other staff people on today. We have Anna Reed, who is our program director out of the Beaverton office, and Libby Kennard is our program lead out of the Eugene office, and they are helping with some of the technology and the backdoor chat boxes and things like that. If you don't know, Parkinson's Resources of Oregon is a local nonprofit organization. We've been serving people with Parkinson's and their families in Oregon and Southwest Washington for over 40 years. Our goal is to help improve the quality of life for people through education, advocacy, support groups, wellness, exercise, programming. A few logistics. Dr. Pfeiffer has agreed to answer questions at the end of his presentation. If you have questions, please use the chat box to type those in, and one of our staff will be monitoring that. We are recording this session today, and we will be posting it on our YouTube link. I will also be sending the link to the recording out to everybody who's attended today as well. I think it's going to be packed with a lot of information, and you may want to be revisiting the lecture to remember some of the things. Lastly, for me is that we do have the two other presentations coming up. If you're interested in attending those, you have to register for each of those independently. So just because you registered for this one, you will not automatically be registered for 2 and number 3 of these series. So I'm going to introduce, sitting next to me is Dr. Jean Donovan. Jean has been very instrumental in helping us create this series and try to get this information out to clients. Jean is also our third speaker, so I am going to have her take over and introduce Dr. Pfeiffer today.
Thank you, Nancy. Let me just say that we are delighted to have Dr. Ronald Pfeiffer speak to us today on the topic of dysautonomia. Dr. Pfeiffer is currently faculty in the neurology department at OHSU, and he's a long way from his home state of Nebraska, where he completed both his undergraduate and his medical degrees. He also completed neurological training at Walter Reed Medical Center in Washington, D.C. I won't go into detail, but his biography is very impressive. It's replete with many clinical trials, publications, and leadership positions in the field of Parkinson's. But the most significant aspect of his accomplishments that are relevant today is his breadth of understanding of the impact of dysautonomia on Parkinson's patients. He exhibits a rare grasp of this complex topic. So thank you, Dr. Pfeiffer, for joining us today.
Well, thank you very much. That's going to be hard to live up to, but we'll get going here. So
Great.
I will go ahead and begin. James Parkinson, way back in 1817, published a fairly long treatise on a disease he named the shaking palsy. And what's really fascinating for me is he based a very thorough description of the features of the disease on 3 patients he examined in his office, an additional 2 people that he talked to on the streets of London, and a 6th person that he just saw walking in the distance. And from those 6 people, he described many of the features of Parkinson's disease. He primarily focused on some of what we would now call motor features, tremor and the slowness in movement that we call bradykinesia. He actually didn't describe rigidity, which isn't surprising since he only actually examined 3 patients. That was identified later as the other of the trio of motor features of Parkinson's disease. Now, James Parkinson also described some of what we would now call non-motor features. In particular, he described constipation, he described urinary difficulties. The thing is, though, after James Parkinson, everybody focused on the motor features of Parkinson's disease, and very little, if anything, was heard about what we now call non-motor features of Parkinson's disease. And it wasn't until the second half of the 20th century that people started to re-recognize, I will say, non-motor features of Parkinson's disease. For example, abnormalities of sensation, impaired sense of smell was identified, behavioral changes, ranging from depression to apathy to cognitive impairment were described. Sleep disorders, particularly REM sleep behavior disorder, fatigue, all of these were described. And along with them, autonomic dysfunction started gaining attention. And over the past 50 years has actually incurred a lot of attention in the setting of Parkinson's disease. And that's what we're going to talk about today. But before we can talk about the features of Parkinson's disease, if we're going to talk about autonomic dysfunction, we got to talk briefly about the autonomic nervous system. The autonomic nervous system, I like to think of it as the part of the nervous system that functions under the radar. It's something, it controls things that we don't have to consciously think about. And so it deals with cardiac function, with gastrointestinal absorption of movement through the intestines, sexual functioning, sweating, all of these things. And there are two aspects or facets to the autonomic nervous system, the sympathetic and the parasympathetic. I like to think of the sympathetic nervous system as like a New Yorker, ready for action. And that's as opposed to the parasympathetic system, which is like the California surfer guy who's relaxed and cool. So when the sympathetic system is functioning, it will increase heart rate, it'll increase cardiac contractility, it'll inhibit digestion because you don't want to be digesting when you're fighting an animal or something. It has effects, it contracts the rectum. I'll let you figure that one out. And has effects on sexual functioning and so on. Whereas the parasympathetic system stimulates digestion, decreases cardiac contractility, decreases heart rate, and so on and so forth. So that's the sort of yin and yang that's all being handled without us consciously thinking about it. And when that autonomic nervous system is affected, as it is in Parkinson's disease, you see problems in the type of things we're going to talk about today. When I was at the University of Tennessee, we did a study looking at symptoms of autonomic dysfunction in people with Parkinson's disease, and looked at the various aspects, the GIs, gastrointestinal, GUs, genital urinary, and across the board. And you can see that in most all of them, people with Parkinson's disease answered yes to more questions than people without Parkinson's disease. And where it becomes most evident is here on the sum column, where people with Parkinson's disease clearly have a lot more autonomic symptoms than people without Parkinson's disease. In a study that was much more elegant, much larger, performed a decade or so later, Koo and his colleagues basically found the same sorts of abnormalities in people with Parkinson's disease. So it's quite clear that autonomic dysfunction is evident in Parkinson's disease and merits our discussion today. And so we'll talk about 5 specific aspects of autonomic function: cardiovascular, gastrointestinal, urinary, sexual, and thermoregulatory function. And we'll spend a little time with each of them, starting with cardiovascular dysfunction. The most important aspect of cardiovascular dysfunction in Parkinson's disease is orthostatic hypotension, and that means blood pressure that drops when a person stands up. And there are actually 2 kinds of orthostatic hypotension. One is what one might call non-neurogenic orthostatic hypotension. These are people who don't have Parkinson's disease or other neurological disorders. They can be normal people, and in non-neurogenic orthostatic hypotension, the blood pressure drops when people stand up, but the pulse rate also increases in response to that. There are a number of things that can cause this type of orthostatic hypotension. Perhaps the most common is volume depletion. If people get dehydrated, if they lose blood, their autonomic system will try and respond because it's still functioning, but it may not be able to do so. So when the blood pressure drops because blood volume is low, the pulse rate increases, trying to compensate for that. But that's not what we're talking about today. We're talking about the second kind of orthostatic hypotension, and that's when the autonomic nervous system is affected, and that's called neurogenic orthostatic hypotension, or NOH. The difference with neurogenic orthostatic hypotension is that the blood pressure drops when standing. That's actually not the difference. That's the similarity. The difference is that the pulse rate doesn't go up. There's no response. And so the blood pressure stays low and continues to get lower sometimes. And that's because the autonomic nervous system isn't working properly. The heart muscle is okay, but it's not getting correct messages. So what is neurogenic orthostatic hypotension? It's defined as a blood pressure of greater than 20 millimeters of mercury in the systolic, or the upper number with blood pressures, or greater than 10 in the diastolic blood pressure when a person goes from lying down to standing up, and again, without a change in pulse rate. This has been studied fairly extensively now in people with Parkinson's disease, and it turns out that almost 60% of people with Parkinson's disease will display some evidence of neurogenic orthostatic hypotension. Now, of that 58%, only about a third of them will actually experience symptoms of neurogenic orthostatic hypotension, whereas the other two-thirds experience no symptoms at all. That doesn't mean they won't down the road, but at the time they're looked at, they're asymptomatic. And it's also important to remember that medications can magnify any of these changes. So, and this is just sort of a graph that kind of shows you what happens to the blood pressure. Here, our little guy is laying down, and his blood pressure is about 120 over 90, it looks like. And here he stands up, and when he stands up, his blood pressure drops to the range of around 70 over 50, and he gets a little woozy, and he stays woozy until he sits down, when the blood pressure goes back up part of the ways, I'm sorry, when he sits down. And then if he were to lay down again, his blood pressure would go back up here. So that's what's happening with neurogenic orthostatic hypotension. Now, to show you that indeed the autonomic nervous system isn't functioning as it should in these patients, MIBG scanning is a nucleotide scan that looks at the autonomic nervous system, in particular sympathetic functioning. And here, this is like looking at a chest x-ray. This is the liver over here. You can ignore that. But look at this horseshoe here. And that's the heart. That's the left ventricle of the heart. And this is a normal individual. And you can see that there's a fair amount of autonomic, of autonomic function going on. In the person with Parkinson's disease, you don't see that. And why don't you see that? Well, these are slides of epicardial nerve fibers, and down here is a normal individual, and you see all these different fibers. The different colors have to do with different transmitters or markings, and they're densely populated, these nerve fibers. But in a person with Parkinson's disease, a lot of those fibers are just plain gone, and so the autonomic nervous system is clearly affected, and that's why these problems occur. So what symptoms do people experience? Well, we've been talking about a sense of lightheadedness when people stand up. It's not a spinning type of vertigo. It's a lightheadedness, feeling like you might faint. And sometimes people actually do go ahead and faint. But that's not the only symptom that people with orthostatic hypotension can experience. They can note disturbances in vision. Their vision becomes cloudy because blood isn't getting up to the retina. They can have impaired thinking, foggy cognition. They can develop a headache that's in what's often called a coat hanger distribution, in that it affects the neck and the shoulders. Or they can have pain in the lower back or even in the rear end. They can become just fatigued and lethargic. They can even become short of breath, all as a result of this orthostatic hypotension. The real danger, of course, is if they faint, and then you can fall and break a hip or who knows what else. So how do you treat neurogenic orthostatic hypotension? First thing to remember is that if people are already on drugs that lower blood pressure, antihypertensive medications, they may need to be adjusted, reduced, or sometimes eliminated. There are non-pharmacologic methods that can be useful in avoiding symptomatic orthostatic hypotension. At least you can avoid activities that increase body temperature, because if your body temperature goes up, your blood vessels dilate to lower the temperature. And when those vessels dilate, there's less blood available to go upstairs to the brain. So if you avoid those activities, you're less likely to have severe hypotension. Liberalizing fluid and salt intake can be useful. Compression stockings can be useful. But unfortunately, the ones that we typically think of going up to your knees, they don't do the job because there's not enough blood supply in the lower leg to make a difference. You really, honestly, truly have to wear waist-high compression stockings to get an effect. I know that's uncomfortable and it's a real pain, and I know that from experience. My dad had Parkinson's disease and he had severe orthostatic hypotension. And when he would come to visit, I would often have to help him get those things on and off. And it's a real chore. And so what happens all too often with patients, when they're prescribed waist-high stockings, they end up in the drawer rather than on the patient. And that's unfortunate because they really do work. They prevented my dad from fainting, but they're uncomfortable and they're a real hassle to get on and off. A little less problematic is the abdominal binder. There's a lot of blood that pools in our abdominal area because that's supplying the intestines and the liver and so on. And so an abdominal binder can actually do a pretty good job of preventing pooling of the blood in that circulation there. And it's a little easier to get on and off. It's kind of like a girdle for guys who don't quite understand what I'm talking about. You'd hear less about it, but it's effective and maybe easier than the waist-high stockings. There are other little tricks that people can do. If you want to do something, you want to go for a 15-minute walk, or you want to play pickleball, and you're worried that your blood pressure might drop while you're doing it. One way to reduce the likelihood of that happening is to quickly drink 2 8-ounce glasses of cold ice water, and that jars the autonomic nervous system and can actually support a blood pressure for 15 to 30 minutes. You can also use various actions or positions to increase peripheral resistance. And rather than tell you about them, I'll show you what they might be. Crossing the leg, and you can see that increases blood pressure a little bit. Putting a knee up on a stool or a chair definitely increases blood pressure. Kneeling, not surprisingly, increases blood pressure. Even crossing a leg like this can increase pressure. So those are little tricks that have nothing to do with medication that people can use. But then there are, for the many people where those kinds of non-pharmacologic maneuvers aren't sufficient, there are drug treatments that can serve the purpose of increasing blood pressure. There are just 2 actually that are approved by the Food and Drug Administration for this purpose. One, midodrine has been, these are always going to be the brand names in parenthesis. Midodrine has been around for quite a while. It's effective and probably is the initial choice for most neurologists when they're treating neurogenic orthostatic hypotension. Droxidopa is a newer medication, therefore more expensive, and is being used more and more. There are also 2 other medicines that have been around a long time, have never received formal approval from the FDA, but they're effective. Fludrocortisone is a steroid, and there are some problems or concerns with using it, although it's easy to use and often, along with the midodrine, are the first 2 choices. Pyridostigmine isn't used very often. It's primarily a medicine for myasthenia gravis, but it can actually improve orthostatic hypotension. Now, there's some other twists on the problem of neurogenic orthostatic hypotension that I want to mention. We've been talking about blood pressure dropping just when you stand up. There's another situation where blood pressure can drop, and that's after you eat. And this is called postprandial neurogenic orthostatic hypotension. And within about 15 minutes after eating, the blood pressure may drop. And that drop in blood pressure can last for up to 3 hours. Typically, it's a large carbohydrate meal that triggers this postprandial hypotension, and elderly people are more at risk than younger people. So how do you treat it? How do you deal with it? Well, simple, obvious things. Don't eat big carbohydrate meals. Maybe eat smaller, more frequent meals. And of course, you can always stay seated for a while after you eat until the risk for this passes. And this is just again, it shows a person before the meal, blood pressure is 128 over, say, 74. They eat, and bingo, their blood pressure drops down to around 80 over 50. And this only goes out to 3 hours, and it's still low. And so you have to be kind of aware and alert that can happen, and be careful. Another part of orthostatic hypotension or autonomic dysfunction from the cardiovascular standpoint that can occur is that when people lie down at night to sleep, their blood pressure may actually increase. Normally, when we lay down to sleep, our blood pressure dips or drops a bit and stays down while we're asleep and then goes back up in the morning. But paradoxically, in people with autonomic dysfunction, the blood pressure may actually go up. And so supine hypertension is actually defined as a blood pressure above 140 over 90 when the person is lying down. And using that, studies have shown that a third to almost a half of people with Parkinson's disease will show either non-dipping, that is, their blood pressure just stays the same, or it'll go up when they're lying down sleeping. Whether you should treat that or not is kind of a tough thing to decide for the doc, because to treat it, you will want to give them a medication that lowers blood pressure, but during the daytime, you're giving them medicine to increase blood pressure. And so you're dealing with opposites there. And most of the time, at least a good chunk of the time, physicians will opt not to go vigorously treating the supine hypertension, with the reason that orthostatic hypotension during the day is potentially immediately dangerous. You fall and break a leg. Whereas the increased blood pressure at night, any consequences it might have are probably a more long-term problem. But there are some people, particularly if the systolic pressure rises to above 60 or certainly above 180, that you do need to treat. And when you do that, you do use antihypertensive drugs, but you want to pick one that has a short duration of action so that any effects it has are worn off by the morning. And this is just a list of various blood pressure medicines that your neurologist or cardiologist might choose in this setting. And this, again, is just another little graph. This is a normal individual. Blood pressure stays pretty steady during the day. Go to sleep at night, the blood pressure drops. That's the dip. And then when morning comes, blood pressure goes back up again. But here's a patient with Parkinson's disease, has these ups and downs during the day that may be related to standing, sitting, and so on. But then at night, you don't see a dip at all. In fact, what you see is an increase in blood pressure that lasts until the morning hours and then goes back down again. So that's supine hypertension in the setting of Parkinson's disease. I want to move on now and talk about gastrointestinal dysfunction. Now, James Parkinson, in his treatise, actually described a number of aspects of GI dysfunction. He described difficulty swallowing here. He describes drooling, or excess saliva, and he describes bowel dysfunction, and which is fascinating to me, given that he only saw those 6 patients. He identified both decreased frequency of bowel movements, that's what torpid means, and he also described difficulty with the act of defecation itself, which we now know to be evident in Parkinson's disease. I got interested in autonomic dysfunction in Parkinson's disease back when I was at the University of Nebraska. And in the late 1980s, early 1990s, we studied a good number of patients. And this was a study where we looked at, I think it was 98 patients with Parkinson's disease and controls that were mostly spouses. And we asked them a lot of questions about gastrointestinal function or dysfunction. And it turned out that there were 5 symptoms or features that were particularly frequently occurring in people with Parkinson's disease. Too much saliva in the mouth with drooling, difficulty swallowing, nausea, decreased frequency of bowel movements, and difficulty with the act of defecation itself. Now, Eamon Quigley, who was the gastroenterologist working with us, later suggested that this nausea wasn't really, our first thought was, well, it's anti-Parkinson medication, but he suggested that it really probably wasn't that, but maybe was impaired gastric emptying or gastroparesis. And subsequently, it's been shown that that's indeed one of the GI features of Parkinson's disease. Dr. Koo, again, and his colleagues in their more larger, more elegant study found basically the same GI symptoms in people with Parkinson's disease. So let's go through each of those briefly. Excess saliva in Parkinson's disease is actually experienced by anywhere from a half to 3/4 of people with PD. Initially, it may be just drooling in the bed at night, but then it can progress ever more frequently and severely during the daytime to what I call the handkerchief stage, where a person may have to carry a handkerchief around and keep daubing the fluid. I actually remember one patient I had that would take paper napkins and roll them up like a cigar and put that in his mouth. So he was carrying around a cigar-like thing that I guess he thought maybe was a little less conspicuous, although I'm not sure if that was correct. So you might think from this that people with Parkinson's disease must make too much saliva. They don't. In fact, when it gets measured, they make less saliva than normal. So that the problem isn't too much saliva, it's that people don't swallow as frequently with Parkinson's disease, nor are they as efficient in their swallowing. And beyond that, people with Parkinson's disease tend to develop stoop posture, the neck flexes forward, and there's a tendency for the mouth to drop open a little bit, and that's a setup for drooling. So what do you do if someone's having drooling that's bothersome to them? Well, first of all, you want to assess for the presence of difficulty swallowing, because that may require specific treatments for dysphagia as opposed to treatments for drooling. You might also consider referral to a speech therapist because they can teach people techniques to minimize drooling. One little trick that people have learned to use is to, in social situations, either chew gum or suck on lemon drops or other hard candy. And what that does is turns swallowing into more of a voluntary and therefore more frequent function rather than the automatic swallowing that's slowed in Parkinson's disease. For people where these kind of maneuvers aren't sufficient, there are ways to reduce saliva production. Drugs that block acetylcholine, they're called anticholinergic drugs, will do this, but they also cause constipation, they cause difficulty with urination, and if they get into the brain, they can cause cognitive impairment. So you don't want to use potent systemic anticholinergic drugs. So what people have resorted to is using drugs with a more localized response. Sublingual atropine eye drops is one way to do that. You put a drop on or under the tongue a couple times a day, and that has its effect on reducing saliva production in the mouth, but it doesn't have a lot of systemic effects because you're not giving large amounts of medication. There's another anticholinergic drug called glycopyrrolate or Robinul, which is given as a pill form, but it doesn't cross the blood-brain barrier, so it doesn't cause the cognitive impairment that you can see with the more globally systemic anticholinergic drugs, but it can cause constipation and urinary difficulties. If that fails, by far the most effective treatment that we have for treating excess saliva is botulinum toxin injections into the salivary glands. It has to be done every 3 or 4 months, but it can be very noticeably and agreeably effective. What about difficulty swallowing? Now, survey studies looking at dysphagia show a fairly broad, anywhere from 30 to over 80% of people describing difficulty swallowing, and that may be a function of the thoroughness of the questionnaires used in the tests as anything. But I think it also illustrates that people may have difficulty swallowing and not be aware of it. And you can confirm that with objective testing, and studies that use objective testing, like the modified barium swallow study, show some abnormality in 3/4 to almost 100% of people with Parkinson's disease. Now, in all of those people, they aren't experiencing symptomatic difficulty swallowing. They may not be aware of it, but it's there, and over time is likely to become more noticeable. It's important to recognize that there are three phases of swallowing. The oral phase, when you're chewing and the tongue pushes the food bolus back into the throat or the pharynx. So there's the oral phase, the pharyngeal phase, and then there's the esophageal phase, where the esophagus is carrying the food from the pharynx down to the stomach. Any of those phases can be affected in Parkinson's disease, and so it's important to have gastroenterology evaluation to see where the problem might reside. The big risk with dysphagia, other than it's uncomfortable, is that it can cause food or liquid to get into the windpipe rather than going down the esophagus, and that's called aspiration, and aspiration can end up with pneumonia. And pneumonia is probably the most common cause of death in people with Parkinson's disease, and may be frequently due to aspiration. And it doesn't necessarily have to be aspiration that people notice. It can be silent, but it's still there. So how do you treat dysphagia? Well, here I think it's really worthwhile. If a person is having noticeable or symptomatic dysphagia, they should see a gastroenterologist and maybe also a speech language pathologist to further characterize the type of swallowing dysfunction that the person is having. Now, the speech language pathologist can train people in swallowing techniques and dietary modifications that can be useful in alleviating dysphagia, although not typically eliminating it. Neurologists can also adjust their Parkinson medication, because there are some people who will respond to increasing levodopa dosage. And then finally, the gastroenterologist looking past the throat and down into the esophagus can be an important thing to look at. Let's go on and talk briefly about impaired gastric emptying or gastroparesis. This is a view of the stomach, and the stomach there is kind of divided into three portions. There's this upper part, the fundus, that's really a receptacle for food as it comes down the esophagus here. This lower part of the stomach is called the antrum, and I think of that as sort of like the cement mixer of the stomach. It grinds food into tiny, tiny particles, and while it's doing that, the policeman here, the pyloric sphincter, remains shut and doesn't let material through that unless it's smaller than 1 millimeter in size. And then it will open up and fluid can get out of the stomach into the small intestine, where things are actually absorbed into our circulation. So if the stomach isn't doing its function, it may not grind the food sufficiently, and so it doesn't get let into the intestine, or the pyloric sphincter may stubbornly not relax when it's supposed to relax, and it holds food in the stomach, and that's impaired gastric emptying or gastroparesis. So what symptoms does gastroparesis produce? Well, reduced appetite. If your stomach is already full of food, you're not going to want a lot more food. So people may become full after just a few bites. And because they're not eating as much, they will typically lose weight down here. Nausea is not infrequent. Even vomiting can occur. Sometimes gastroesophageal reflux will occur because the stomach gets so full that the food sneaks back up through that upper esophageal sphincter or lower esophageal sphincter and gets back into the esophagus, causing heartburn. And then there can be abdominal bloating and distension. So a fairly wide array of symptoms can be a problem with gastroparesis. And gastroparesis can be evident even early in Parkinson's disease. Importantly, it's not just food that can be affected by impaired gastric emptying. Medication can be also, and in particular, levodopa. Levodopa has to get into the intestine to be absorbed. If it gets held up in the stomach, it can't act. And in fact, while it's held up in the stomach, some of it can be degraded. And so it's not available when it does get into the intestine. So it can produce symptoms, but it can also produce difficulty with medication effectiveness. So how do you treat gastroparesis? There are always non-pharmacologic approaches, and one is to adhere to a small particle size, what's called a gastroparetic diet, where you eat small, frequent meals, you drink fluids throughout the meal, and then you remain upright or walking for a couple hours after the meal. And that is helpful for some people, and obviously not for everybody. There are drugs that can improve gastric emptying, but there's a big caveat with the two that one might think about, metoclopramide or Reglan. And both of these drugs work by blocking dopamine. So when you hear blocking dopamine, you think from a Parkinson's standpoint, well, I don't want to do that because dopamine is what helps as far as movement when it gets into the brain. Metoclopramide crosses the blood-brain barrier. It does get into the brain. And so it can induce Parkinsonism even in people who don't have Parkinson's disease. So people with Parkinson's disease should not take metoclopramide or Reglan, period. There's another prokinetic dopamine antagonist called domperidone. The problem with domperidone is that the good thing about domperidone is that it doesn't cross the blood-brain barrier. So it doesn't cause the Parkinsonism. But on the other hand, it doesn't cross the Canadian-US border either. It's not approved for use in the United States. And it used to be that you could still order it through Canadian pharmacies, but that's been stopped. And so it's basically not available. If you can't improve gastric emptying, what about with regard to the medications? Are there ways around it? Yeah, now there actually are a number of ways to try and get around it so that the medicine actually gets into our system. In the last year or so, subcutaneous constant infusion of both levodopa, that's Vyalev, or apomorphine, that's Onapgo, have become approved by the Food and Drug Administration and can be used. Of course, you have to be sticking needles in your abdomen, and so it's a little bit of a pain to use, but it works. Duopa, the levodopa intestinal gel infusion, same thing, except there you're depositing the levodopa into the intestine as opposed to into the systemic circulation. And then there's transdermal rotigotine or Rytary that gets in by skin absorption, gets into the system. So they can be useful. Rytary in and of itself, probably not, but these other ways are certainly ways to go. There have been several small studies where if impaired relaxation of the pyloric sphincter is noted, injecting botulinum toxin into the pyloric sphincter can be useful in alleviating emptying, but that's not been broadly studied or utilized, and that's all I'll say about that, I guess. Small intestinal dysfunction in Parkinson's disease has received very little attention. It's very difficult to study because it's so hard to get at the small intestine. And so what has been noticed in Parkinson's disease is there are abnormal motor patterns. Small intestinal dilatation has been noted in some people. But the clinical consequences of it are not entirely clear. Small intestinal bacterial overgrowth, or SIBO, has been described in patients with Parkinson's disease, but its significance is not entirely clear. And also increased permeability of the intestine has been reported, and that in turn may set up inflammation, and some people suggest that may trigger the whole pathologic process that we call Parkinson's disease. But a lot more needs to be learned about small intestinal dysfunction, and really not much has been learned about treating it. Bowel dysfunction, again, there are two aspects of bowel dysfunction in Parkinson's disease: decreased frequency of bowel movements and difficulty with the act of defecation itself. Let's talk first about decreased frequency or constipation. The definition that's typically used is fewer than 3 bowel movements per week. And if you use that definition, studies would suggest that anywhere from 20 to almost 80% of people with Parkinson's disease may have this problem. Why do they have it? Well, it's because things are moving through the colon much more slowly. So colon transit time is prolonged, and this prolongation of colon transit time is evident in up to 80% of people with Parkinson's disease. When we did our studies, the colon transit time was over twice as long as normal. Other people report even higher average colon transit time in Parkinson patients. So how do you deal with that? Well, initially, sort of a common sense approach would be to increase dietary fiber or psyllium and increase fluids to get things moving through the colon more quickly. And if you're on medications like anticholinergic drugs that might slow things moving through, you might want to discontinue those medications. If that's not sufficient, and it often isn't, uh, osmotic laxatives are the sort of the next step. Polyethylene glycol or Miralax is the one that's typically utilized here in the United States, and it can be very effective. It's a powder, it's easy to use, and the dose kind of depends on how bad your problems are. If polyethylene glycol doesn't work, then there are medications that either increase secretion into the intestine and thus improve its motility, or they directly stimulate movement in the intestine. These are drugs like lubiprostone, linaclotide, prucalopride. These are their brand names. And there have been some studies looking at them specifically in Parkinson's disease, but not a lot. But they certainly can be tried in people with Parkinson's disease. Question often comes up, what about probiotics? And I think the most honest answer is at this point, evidence supporting the efficacy of probiotics in Parkinson's disease is insufficient. That doesn't mean they're not going to prove to be effective. It just means that more work needs to be done. Moving on to defecatory dysfunction, develops in about 2/3 of patients with Parkinson's disease and is characterized by increased straining, pain upon defecation, and incomplete emptying. To understand why that happens, let's just look at what happens with normal defecation. And here you have a view. Here's the rectum, the end of the large intestine, the rectum, and here's oh, I didn't mean to do that. And so when a person is just minding their business, the sphincter muscles are constricted a little bit, and this muscle here is called the puborectalis muscle, and it wraps around much like, and I don't know if you can see it because I see the little squares up here, much like the band or the sash on a curtain is making a kink in the curtain. And that's to impede and keep stuff here in the rectum. Now, if you got to go, but you're not near a bathroom, your puborectalis muscle will tighten up even more. Your sphincter muscles will tighten even more to get you through till you can get to the bathroom. But then what can happen with people with Parkinson's disease is when it's time to have a bowel movement, the sphincter muscles may or may not relax like they're supposed to, and the puborectalis muscle may not relax. And so this kink called the anorectal angle is maintained rather than loosened. And in addition to that, there's supposed to be a contraction of the abdominal wall muscles, the diaphragm, and even some of the pharyngeal muscles to increase intra-abdominal pressure and help ease things out. So that's the way things may happen. And so in Parkinson's disease, you may have impaired motor control and coordination of these muscles so that when a person's trying to have a bowel movement, the sphincters don't relax. The anorectal angle doesn't open up because the puborectalis muscle doesn't relax. And the other muscles like the diaphragm and the abdominal muscles don't constrict like they're supposed to increase pressure. And this all is probably related to Parkinson's disease itself, bradykinesia and rigidity in those muscles, and maybe some dystonia in the sphincters that are not relaxing like they're supposed to. How do you deal with that? Probably the most common way it's dealt with now is with pelvic floor physical therapy and biofeedback treatments that are performed by specialized physical therapists, and their aim is to get those muscles to be more coordinated and contract and relax when they're supposed to. Stool softeners can be helpful in getting stuff to go through there, but if you use too much of that, then you've got diarrhea. Dopaminergic medicines like levodopa or apomorphine are sometimes beneficial in improving defecatory function. And there have even been some studies looking at botulinum toxin injections. See botulinum toxin everywhere nowadays, but botulinum toxin injections into the puborectalis muscle and the anal canal muscles, and that it can be helpful for some people. Urinary dysfunction. Uh, there are two types of urinary dysfunction. There's an overactive or bladder or irritative urinary symptoms, or an underactive or obstructed urinary symptoms or bladder. The most common in Parkinson's disease urinary problem is this irritable or irritative urinary bladder or overactive bladder. And people with an overactive bladder will have to frequently urinate. They may have to get up multiple times at night. When they do urinate, it may be just small amounts. They may have to get to the toilet really quickly, and they may have incontinence on the way to get there. And this is just a quick graph. You can see that people with Parkinson's disease, black is bad, or meaning you're having more frequent symptomatology. And compared to the control people, there are a lot more symptoms in people with Parkinson's disease. How do you deal with an overactive bladder? Again, there are non-pharmacologic approaches. You can reduce caffeine and alcohol intake. Therapists can teach suppression and distraction techniques that can be useful. Pelvic floor exercises, adhering to avoiding schedule, all can be useful, but for some people it's not sufficient. And then pharmacologic approaches are needed. Older non-selective anticholinergic drugs like oxybutynin and tolterenine should probably not be utilized because they get into the brain and can magnify Parkinson's symptoms. But there are newer selective anticholinergic drugs that can be useful. Solifenacin or Vesicare selectively antagonizes M3 receptors, which are primarily on the bladder. And so it's fairly specific for bladder function. Trospium or Sanctura works differently. It's an anticholinergic, but it doesn't cross the blood-brain barrier. So it's relatively restricted to bladder function, although not totally. And then there's darafenacin or Enablix, which is both a selective receptor antagonist and doesn't cross the blood-brain barrier. So in theory, that would be the best anticholinergic drug to use. There are also drugs that work on other systems like the noradrenergic system that can be useful. Mirabegron or Myrbetriq is the one that's currently available. Obstructive urinary symptoms are less common in patients with Parkinson's disease, but still account for a quarter or more of urinary symptoms. People with obstructive symptoms have difficulty initiating urination, and they have a weak urinary stream. They may develop incontinence, but it's overflow incontinence from the bladder just overfilling and overcoming the resistance the sphincters are playing. This type of obstructive symptomatology in Parkinson's patients is due to failure of the urethral sphincter to relax when it's supposed to, due to sphincter bradykinesia, which is evident in a fair significant number of people with Parkinson's disease. And it doesn't necessarily produce symptoms, but it can. And of course, in men, you always have to remember that prostatic hypertrophy can be evident, particularly in older men, and that's an entirely different process for the urologist to handle, not the neurologist. So if prostatic hypertrophy is present, you get the person to the urologist. If it's not, and if it's the urethral sphincter bradykinesia, sometimes that'll respond to increasing levodopa therapy. There have been studies looking at botulinum toxin injections into the urethral sphincter in people with obstructive urinary symptoms, but it hasn't been specifically evaluated for people with Parkinson's disease. Ultimately, intermittent catheterization may be the most effective treatment for obstructive urinary symptoms in patients with Parkinson's disease. Sexual dysfunction, I'll just address fairly briefly here. Reduced or impaired sexual function is actually very common in people with Parkinson's disease. Men may have erectile dysfunction. They may have decreased desire or libido, or they may have decreased ability to achieve orgasm. Women may have reduced vaginal sensitivity, and they may have decreased desire or libido, just like men do. Significant percentages actually have these problems. Now, Sexual dysfunction in Parkinson's disease often isn't just the Parkinson's disease itself, because other things can be going on. Depression in men, testosterone deficiency, and various medications all can affect sexual functioning and should be addressed if they are present. The other aspect of sexual dysfunction in Parkinson's disease receives less attention, but can be really devastating also, and that's excessive or distorted sexual functioning. It's called dopamine dysregulation syndrome. This occurs primarily in men and is characterized by impulse control difficulty. So people with this problem may develop compulsive buying or compulsive gambling or hypersexual behavior, visiting prostitutes and the like. And as you can guess, that can just destroy marriages and really cause problems. And the thing is, it's caused by Parkinson medication, particularly dopamine agonists, bromocriptine in years past, and the newer ropinirole and so on are the most notorious agents for this, but levodopa occasionally can do the same thing. And the thing about this is patients are not particularly prone to telling the docs that, hey, I'm losing thousands of dollars gambling. And I had one patient who lost more than a few $1,000s gambling. Other patient whose marriage was destroyed by hypersexual behavior. But people are not going to be very eager to tell docs about it. Docs are often busy and rushed and don't take the time to ask about this. So spouses or family members need to be aware of this potential problem and alert physicians to it if it's present, because this can be treated by reducing doses or stopping the offending medications. What about thermoregulatory dysfunction in Parkinson's disease? Hasn't received much attention at all in Parkinson's disease, but it's probably more common than recognized. And there are two aspects to thermoregulatory function. First, there's the sweating. So people with Parkinson's disease may have too much sweating, or less commonly, they may have too little sweating. And then people with Parkinson's disease may have elevated temperature or low body temperature. So let's talk first about sweating. Dishydrosis occurs in 30 to 60% of people with Parkinson's disease, and it can be either too much sweating or too little sweating, and they actually can exist at the same time. Some parts of the body may sweat too much. They may sweat too little, and so in response to that, other parts of the body sweat more than they should, and so you get the worst of both worlds there. Too much sweating or hyperhidrosis primarily involves the head and neck, and there can be sun drenching sweats for people. Most often, this is going to occur when their effectiveness of their Parkinson medication is worn off, or it may occur while the medicine is wearing off, or in contrast, it may occur when people are overdosed, when they're dyskinetic and writhing and wiggling all over the place. But it can also occur when people aren't even on medication yet. So it's not strictly medication related, but it certainly can have a negative impact on quality of life. Nobody wants to be out in public when they're sweating up a storm. So treatment sometimes becomes necessary. Now, keeping temperature cooler in the environment, wearing breathable fabrics is sort of an initial way to try and deal with it. Making sure one drinks enough fluids is important. Adjusting Parkinson medication to reduce off time and to reduce dyskinesia, for that matter, can be important. People have tried using botulinum toxin injections, but the problem is with sweating, it covers too large of an area to make botulinum toxin injections practical for the most part. As far as hypothermia and hyperthermia, both have been described in the setting of Parkinson's disease. Reduced body temperature can be induced by medications. I had the patients once on bromocriptine who reliably would find his temperature, body temperature, would diminish to an uncomfortable degree. And when he was taken off medication, that went away. And people with Parkinsonian hypothermia, if you want to call it that, can be real sensitive to cold exposure. So that's much more of an issue in Minnesota than it would be in Florida, say. Hyperthermia, on the other hand, is increased body temperature and can happen. And this is where you have to be really alert also. It can be induced by sudden withdrawal of Parkinson medications. And when is that likely to happen? Well, when people get admitted to the hospital, there can be mix-ups or delays in getting medication, and that can end up with what's called dopamine dysregulation syndrome. I'm sorry, it can end up with I'm blanking on the correct name for it, but it's sudden withdrawal, temperature goes way high, and that can be lethal. And so if you or your spouse with Parkinson's disease or vice versa is being admitted to the hospital, make sure that they get their medication. Be on the docs and the nurses about that. So I think I probably stretched my time limits a little bit. I apologize for that. And I'd be happy to answer any questions people might have.
You want me? I'll go ahead. I think we're doing okay on time, and we can go a few minutes past 5 if we need to. There weren't too many questions here. One person asked you if you would say something about non-orthostatic hypotension. I think you did after they had posted that.
I don't know if I specifically addressed, I think the person is asking about blood pressure that's just constantly low.
Mm-hmm.
And I didn't say anything about that because that's not something that's specific to Parkinson's disease. It's related to more general cardiovascular function. And that's something that would be best dealt with by an internist or a generalist.
Okay, we'll move on. We have one person who asked a couple questions that was more about when you're having some orthostatic hypotension, but it's just kind of mild. So if someone has some lightheadedness and faintness, but the blood pressure is only dropping by only 10 and not 20 points, and the pulse is only rising by 5 beats per minute, is there anything that you would suggest? And do you think that, because then there's a follow-up question with this lightheadedness when standing, but having a normal blood pressure, could this be abnormal cerebral blood flow issues?
Well, I guess the first thing I would say is that too often in doctors' offices, when blood pressure is examined, they just take it when you're sitting, and they don't actually do more formal blood pressure testing. They may do it sitting and standing, but even that is not ideal. Lying supine to standing is the ideal way to do that. And so if the blood pressures that the person is talking about were not obtained supine to standing, that may not be the whole picture, and more formal testing may identify more clear-cut orthostatic hypotension. There is formal autonomic function testing that can be also ordered and performed that uses a tilt table and is much more elegant than just lying and standing in the doctor's office. There actually have been some suggestions that you can look at sitting to standing blood pressure, and there a drop in 10 systolic and 5 diastolic is viewed by some people as significant. And if I remember right, the person's description of the drop was in that range. So
Yes.
Further evaluation might be appropriate for that person.
Okay, thank you. That's helpful. There's a couple other questions I'm going to maybe set to the end. But one question, when you're talking about the gastric slowing, is we've heard a lot about GLP-1s might show promise for Parkinson's, which is interesting because part of the purpose of that is to slow the gastric system so that someone's not as hungry, right?
Yeah. And so if anything, Parkinson patients might want to be a little leery of those medications because of their potential in someone who's already prone to gastroparesis, actually producing gastroparesis.
Okay. Are there any links between Crohn's and urinary incontinence with Parkinson's? Because the GI symptoms seem to be pretty similar.
I'm not aware of any connection between urinary symptoms with regard to Crohn's and Parkinson's, but very clearly there are some genetic abnormalities that are seen in both disorders. And so there's a fair literature on interaction or relatedness of inflammatory bowel disease and Parkinson's disease,
Okay.
with the idea that both may have their origin within the GI system.
Right. The person corrected me. What they were abbreviating was ulcerative colitis. So that's
Same thing is true, although the studies more are more focused on Crohn's disease, but ulcerative colitis, it falls in that same category of inflammatory bowel disease.
Okay, thank you. And what causes the decrease in sexual desire among female persons with Parkinson's?
I don't know the answer to that, and I think that's a reflection of there hasn't been a lot of study of sexual problems in Parkinson's disease.
Mhm.
There have been some, and there's a literature on it, but it's not nearly as extensive as these other aspects. And so I'm not sure whether that question has ever adequately been addressed.
Okay. And then getting back to these other two questions that I'm not sure really relate to this topic, but I'll ask you. I saw an article that human PEGI virus, HPGV, is found in the brains and spinal fluid of people with Parkinson's. Is there a possibility that we could isolate this virus, and would that then be a treatment to cure Parkinson's?
My simple answer is I don't know.
Okay.
And I'll have to go do some reading on that.
Yeah, okay. And then another question about a different drug is tavapadon, Tavapadon, tavapadone. Is it found to be helpful in relieving symptoms of Parkinson's?
Again, that's not one that I'm familiar with.
Okay, so we had
Well,
some deep dives there.
I'll plead dumbness twice.
Okay, very good. Well, I'm going to just double check that nobody jumped in with anything else. There is no treatment for delayed or no orgasm in men with Parkinson's. Is that true?
Well, I don't know if some of the drugs that are available, Viagra and so on, might be useful in that regard. You have to be careful in people with Parkinson's disease who have autonomic dysfunction, because that may aggravate orthostatic hypotension and so on. And it wouldn't be good to be feigning.
Yes. Okay, and maybe we might consider this our last question. I'm not sure where we're at on time, but it says, I have trouble getting my heart rate above 120 during exercise. Is this Parkinson's related?
I suppose it could be. On the other hand, it could be that just physically you're not able. I have no idea how severe that person's Parkinson's disease is, but they may be in a situation where just physically they can't stress the system enough to get it up.
Okay. All right. Well, Jean and Nancy, do you think that that's good?
Yeah, I think that's fabulous. I think that was an outstanding, so much great information.
Yes.
So
I just would like to say a few words about our next talk. And first of all, Dr. Pfeiffer, thank you for doing this for us and providing so much general information about dysautonomia. Session 2 will feature Dr. Lenny Svensson. She's a physical therapist from the University of Utah, and she will focus on one of the overlooked aspects of Parkinson's, cardiovascular autonomic dysautonomia. And in that, she will discuss how to recognize this condition, why is it important, and what sort of exercises can help. And I have a feeling she may cover the question that just came up about inability to get the heart rate above 120 with exercise and dysautonomia. So We look forward to seeing many of you and hopefully all of you next time, which is February 25th. Same time, 4 to 5 p.m., same place. So thank you all for participating, and we've had I think, a very productive class. So thank you very, very much, Dr. Pfeiffer.
Yes, Dr.
Thank
Pfeiffer.
you for having me.
Great.
Well, we'd have you anytime. Thanks. All right. Good night, everybody.